Good morning to everybody, and thank you so much for joining us. My name is Ann Disher, and I'm the Executive Director of the Child and Family Policy Center. I'm here this morning with Mary Nell Treffs, the Center's Health Policy Associate, and we're so happy to have you on the line to talk through our new brief, Guiding Principles for Strengthening Iowa's Medicaid Program. We mailed out hard copies of the brief on Friday, so you may have already received it, and if not, you should be getting it quite soon, I would think. Right up front, I do want to cop to our institutional bias around Medicaid. We have one. At our shop, we're big fans. The center's been around for nearly 30 years, and during that time, we have advocated for a robust Medicaid program and a Medicaid program that works hand in hand with a robust Hawkeye program to get Iowa kids the health care they need to be healthy. We supported the 2013 Medicaid expansion because we thought, and we still think, that it was the right thing for our state to help low-income Iowans get the care they need without having to choose between their health and paying the rent or their mortgage. So we certainly have a point of view, and I'm thinking we may well have some folks on the line who've come to different conclusions on some aspects of Medicaid along the road. And we're really happy to talk to folks who come at this from lots of different angles, and we hope we can offer some useful thinking to everybody. In fact, that's really our main goal with this brief, to try to move the conversation about Medicaid in Iowa beyond its currently highly politicized state. At this point, it actually feels incredibly unhelpful to keep arguing around Medicaid, and particularly around managed care, best thing ever, or managed care, the devil. I think our position is, let's just make it work. So I'm going to start out the presentation today. First, I'm going to give you all a very brief history of Medicaid in Iowa. As someone who was a history major when she was at Luther College up in Decorah many years ago, I think there's real value in learning from our past and how we got the program that we have today. And then after that, I'll share a little data about our Medicaid program today and who it serves. Then I'm going to turn things over to Mary Nell, who will walk us through those guiding principles we've promised. And then finally, we want to share a brief video we've produced, and it was really fun to do it. A shout out to our 13-year-old narrator. It's really our closing argument about Medicaid, our ask of you as our state's leaders. So anyway, let's plow right ahead and get into this thing. So again, that brief history is pretty brief. So I'm going to start back at the very beginning of Medicaid, but you notice the story starts really when Lyndon Johnson signs Medicare into law as Title 18 of the Social Security Act. And that was the lead story of the day, really. In fact, the photo you can see there shows President Lyndon Johnson signing the bill, and next to him is President Harry Truman. And President Truman was actually the first president to talk about offering some sort of public insurance to seniors. And so when they finally got the bill through, President Johnson actually gave the first Medicare card to President Truman. And then the kind of secondary thing of that day was signing Medicaid into law as Title 19, which of course folks still really sometimes refer to the program as, and it refers to its title of the Social Security Act. And Medicaid then really did a lot of what it does, at least what it did then, it still does today. It gives states the option of receiving federal funds to provide health services to low-income children, caretaker relatives, the blind, and individuals with disabilities. That was its sort of initial charge. It was then, again, as now, a state-federal partnership, meaning that the federal government provides a share of the funding and sets some broad parameters by which states operate the program. And of course, then it was tied to participation in cash welfare, what was then aid to dependent children and later became aid to families with dependent children. So it was really a program, an insurance program for folks who were receiving cash welfare. 2 years later, or really a year and a half after the option to take Medicaid became possible for states, Iowa adopted Medicaid. And it actually followed 27 other states when it started its program. So you can see actually it was most states really got in fairly early into the process, and within 4 years nearly all states were participating. I think Arizona was the outlier that didn't adopt Medicaid until I believe the early 80s. The same year, the federal government established Medicaid's early and periodic screening, diagnosis, and treatment benefit. And that is, I think Mary Nell and I often say, the world's worst acronym, EPSDT, but it's actually an incredibly important part of our Medicaid program yet today. It's the child health benefit. It covers comprehensive health services to promote healthy development and prevent, really, or mitigate disabling conditions. And, it's really an interesting story about EPSDT. The genesis was actually a report a few years earlier called 1/3 of a Nation, and you can see an image of it there, a report on young men found unqualified for military service. They found that approximately 1/3 of young men in the military age group did not meet the required standards of health and education, that they couldn't serve. And it caused a lot of thinking about what do we do, and they realized a lot of the reasons why young men weren't able to serve is because of health conditions that had their genesis in childhood. So this was a benefit intended to address the fact that we had young adults that had already significant health problems that were preventable. I'm going to skip ahead really to, I think, a period, the 80s and 90s, this period where the program really started expanding. There was the Budget Act of 1981 established a couple of different waivers. And of course, waivers are things that states, it's a proposal that the state writes to the federal government to do things a little different than the standard Medicaid law allows. So this offered two waiver options to states. One, to cover long-term care services for individuals who would otherwise require institutional care. So is this shift acknowledging that there was this need, right, for folks to get services in the home, in the community, instead of being institutionalized. And so a way to sort of push the program a little bit to serve this unmet need. Otherwise, what was happening is folks needed to be institutionalized to get that care. The other waiver in that act was actually a waiver that helped facilitate the use of managed care in Medicaid. The next year was another waiver option, right? States get the option to expand Medicaid to children under 19 with disabilities to receive home-based care regardless of parents' income. Again, the alternative to that was, in order to be a family of one and be eligible for Medicaid, a child couldn't be at home. They had to be institutionalized. And they're still today called Katie Beckett waivers. And this is, to me, an important Iowa story because Katie Beckett was an Iowan. She grew up in Cedar Rapids. And actually, there's a picture of her, Katie Beckett, with President Ronald Reagan at the Cedar Rapids airport. President Reagan was really moved by her story and became an advocate for this particular waiver option to be able to serve the needs of kids with complex health needs at home instead of institutions. And Katie Beckett actually lived into her 30s and continued to be really an advocate for folks with special health needs and an advocate for Medicaid, a really lovely, important Iowa story wrinkle to our national Medicaid program. A few years later, then, states get the option to cover pregnant women and infants up to 100% of the federal poverty level, regardless of AFDC participation. So you can see this unwinding, where Medicaid no longer is so strictly tied. You can see it in those other milestones, too, no longer so strictly tied to participation in cash welfare. In 1989, that EPSDT benefit is broadened, and it requires states to provide medically necessary treatment to children, even if the needed service is one that the state has chosen not to provide for the rest of the Medicaid population. Again, that really just powerful benefit that helps kids get the services they need, the well services, preventive services, to set them off on a healthy track to adulthood. We love EPSDT, so there's that. That same year, states were required, again, if they're going to participate in Medicaid, which at this point every state was, to provide Medicaid to pregnant women and children up to age 5 with incomes up to 133% of the poverty level. And of course, the reason that's happening is that folks are identifying that there's this population of kids who are uninsured, right? They're doing just a little bit too much for Medicaid, but they're not able to get private insurance. 1995, taking advantage of some of that federal flexibility, Iowa's Medicaid program contracted with a for-profit managed care organization, an MCO, of course, to administer its behavioral health services. That relationship with the company that became known as Magellan Behavioral Health Services, that actually lasted until the state did its most recent transition to everything being in managed care. So Iowa's had a small part of its Medicaid services in managed care for a long time. And I think the impetus for that really was, behavioral health is an important part of Medicaid, but it's still a relatively small part of Medicaid. And I think the state saw this as a way both to, test some cost saving, test different way of providing services, but also to really assure that behavioral health services weren't getting lost in the shuffle. In 1996, of course, President Clinton signed into law the big welfare reform law, and it did many things, frankly, but the biggest thing it did is it replaced aid to families with dependent children, which was essentially an entitlement, with TANF, which is a block grant, and we can talk about that another day. But it also severed those last links between cash assistance and Medicaid. There was no longer any need to be on cash welfare to be able to access Medicaid. It became essentially its own freestanding, really health insurance program, which really is what Medicaid is. In 1997, the Balanced Budget Act created the CHIP program, the Children's Health Insurance Program. And again, it's looking at that unmet need, kids whose families made too much for Medicaid but couldn't afford private insurance. At that point in 1997, 23% of low-income children were still uninsured. And they were largely kids in that gap between Medicaid and private coverage. That's what CHIP was created, to work hand in hand with Medicaid to catch kids who still needed that public insurance but made too much for Medicaid. Iowa picked up the option to implement CHIP just the next year, and we still have a really important CHIP program, which of course we call Hawkeye here in Iowa. In 2010, President Obama signed the ACA into effect, which also, as you well know, did many, many things. But for our discussions today, the big thing is that it expanded Medicaid eligibility to nearly all adults under age 65 whose incomes were up to 133% of the federal poverty level. Of course, we know the Supreme Court came in a little later and said, well, hang on, state participation is actually optional. You can't make them participate, which set off, the debate that's still really going on around our country as states decide whether or not they're going to expand Medicaid to that low-income adult population. Iowa really was, again, an early adopter of Medicaid expansion. It was a bipartisan compromise, so Iowa actually wrote a waiver to do their program a little bit differently. But the end result was we expanded Medicaid for working-age adults. In 2015, Governor Branstad announced that Iowa would convert its entire Medicaid program to managed care. By the standards of other states, was a pretty big transition that happened in a pretty short amount of time, just 15 months from announcement to full implementation. And of course, what I don't want to do is rehash the last, 2+ years, other than to say, of course, the implementation proved to be operationally challenging and as we all know, politically contentious. So that's my history lesson. And the point of that isn't to rehash those problems, and the point of it isn't to really cast any particular blame at this point. The point is to remember why Medicaid has grown and changed over time. And it's really in response to unmet needs, to provide services when private insurance didn't or couldn't. For folks who either couldn't afford or didn't have access to private insurance, or for whom their private insurance wasn't enough. Like, again, a lot of families who have kids with complicated health needs, they might have their private insurance as their primary insurer. Medicaid is a secondary insurer to cover those services that private insurance doesn't. And despite all of the current political and operational challenges, right, it's still this incredibly powerful and important program for our state. It makes it possible for thousands of low-income Iowans to get and stay healthy. And I guess our message is that it's just really too important not to work. And I want to walk through a little bit of, really who's getting served by Medicaid. It serves 1 in 2 of every individuals in Iowa with disabilities. So a very important source of insurance for folks with complicated health needs. It serves 1 in 7 adults aged 19 to 64. Again, parents of children on Medicaid and low-income workers themselves, who most of whom work, 72% of adults on Medicaid work, but they work in the kinds of jobs that are needed services in our community, right? Home health care, food service, child care, but they just either don't have access to benefits or they can't afford them. So important coverage for that group of adults. It also covers 1 in 7 Medicare beneficiaries, and these are largely, again, low-income folks. It helps with copays, deductibles. I think it's the Part D part of Medicare, helps subsidize that so folks can have comprehensive coverage. And then it serves 4 and 9 nursing home residents. So again, a very important part of coverage of protecting seniors in their later parts of lives. And then finally, of course, a group that's near and dear to our collective hearts at the Child and Family Policy Center, it covers nearly 1 in 3 Iowa children. And I will tell you that number, I think, which is like 29% is what that 1 in 3, nearly 1 in 3 means. That's like a point-in-time snapshot of the percentage of kids covered by Medicaid. You'll sometimes see a number that's closer to 40%. That number is the percentage of children who are covered by Medicaid and CHIP together, both of these numbers, at any point during the year. So, of course, that's a higher percent, right, because there's some kids who turn it on and off the program during the year. So either way, a really important source of coverage for children. And I guess we should note that 55% of Iowa Medicaid enrollees are children. I think DHS says the typical Medicaid enrollee is a 9-year-old who gets well child visits and, has the occasional ear infection. Most Medicaid enrollees are children. And they cover higher shares of our most vulnerable kids. So 29% of all children, 40% of infants, toddlers, and preschoolers, of course, who are in those years when they're going through their most rapid development, and when preventive care and well child care and early intervention makes the most difference. Covers 47% of children with disabilities and other special health care needs, 79% of children in or near poverty, and of course 100% of children in foster care. Kids in foster care are on Medicaid. This map's actually not in the brief, but I thought it might be interesting for the folks on the phone, and we'll send slides out after this presentation so you can get a better look at the map. But I did want to just share the county level data showing the percentage of children enrolled in Medicaid and CHIP. And the reason why we include Medicaid and CHIP together is that the census data, they ask public insurance coverage, Medicaid or CHIP together. So it's both, but the majority of kids in that group are actually covered by Medicaid. Our Medicaid program is significantly larger than our CHIP program, although obviously both are important. So you can see when you look at the county level data, it ranges from 14% of kids covered in Dallas County, which of course is the western suburbs of the Des Moines metropolitan area, up to as high as 50%, half of kids in Decatur County and that southern tier of states. So really in every county an important source of coverage for children. And I did also just want to quickly share with you a similar map that looks at the percentage of adults enrolled in Medicaid. And it's the years 2012 through 16, and it's actually an average of those. It's a 5-year estimate from the Census Bureau. And the reason why we look at averaged data over multiple years is just to make the data more reliable, because of course some of our counties have fairly low population. So there's less margin of error, more reliable data if we look at a 5-year average. So you can see that the percentages overall, of course, are much lower than the share of children covered, but still important. 3% of adults in Sioux and Wenatchee counties, both up in the northern parts of our states, up to a high of 15% in Jefferson County, which is Fairfield in the southeast corner of the state. So that's sort of our background, our Medicaid 101, and now we really want to talk about the what comes next part of our presentation, which of course is those guiding principles. And I am going to turn the conversation over to Mary Nell, but I'm going to hold the table for 1 minute to just say a quick word about managed care, which I feel like in any Medicaid conversation in Iowa right now is a little bit of the elephant in the room. And I guess here's our thing. Here's our thing on managed care. These guiding principles don't assume any particular service delivery method, and of course there's lots of options, not just all fee-for-service, which is what we used to have, or all managed care, or something in between. But given the election results, I guess we assume managed care appears to stay, likely to stay at least in some form. So this is our thinking about managed care, and it just really is sort of walking back to its most basics, what managed care does. And managed care essentially moves the financial risk for providing covered Medicaid services from the state to MCOs. States pay the MCOs a fixed amount per member per month. That's often called the capitation rate when you get deeper into this. It's the amount that the state pays to MCOs each month. And what that does is it gives the states, of course, some consistency, knows what its budget's going to be, at least if the capitation rate is set correctly. And then in theory, it gives MCOs it gives MCOs then an incentive to act in certain ways, because if the MCO spends more on covered services than it gets from the state, the MCO absorbs the loss. But if it spends less, it gets to keep the difference. That's the essential economic incentive here for MCOs. So MCOs have an incentive to manage costs, and they can do so in two, basic ways, right? They can coordinate care to reduce the unnecessary use of high-cost services, right? They can help manage chronic health conditions, coordinate care so that we're avoiding costly hospitalizations and ER visits. Like that's the example, right? Fee-for-service basically just pays for volume. Somebody goes to the doctor, they get paid. The idea is MCOs can have an incentive to help coordinate care, head off high-cost care, focus on preventive care and management. So that's one way they can make money, and I think that's the way that generally people want to see managed care programs work. Now, the other way they can do it, of course, is by limiting access to services and shifting the risk to providers. So they can set up cumbersome pre-authorization processes. They can use kind of gatekeeping processes. They can deny services. Well, I assume most Iowans would rather see MCOs make their money in the first way and not the second way. But there is evidence, of course, both of these can work for good or for bad. So in successful managed care programs across the country, the state effectively manages those incentives, right? They mitigate the incentives for MCOs to limit services. You can do penalties. You can reward them for doing the right thing, right? And because then you can promote accountability for coordinating accessible quality care. So we want them to do the coordinating. We don't want them to limit services. That, ultimately Medicaid is still the state's responsibility, and it's up to the state to manage the MCOs. So if Iowa is going to continue to use managed care, we should do both. And if I was going to continue to use managed care, we should have one of the best managed care programs in the country. There's no reason Iowans can't offer and design and implement a really good managed care program. Most states use managed care. The vast majority of kids covered on Medicaid are covered under managed care arrangements. We've never taken a position pro or con managed care, but our position is whatever we're going to use, let's do it well. Let's have our eyes on the prize and make it work well for vulnerable Iowans. So that's our sort of basic thought about managed care. Now I'm going to turn the presentation over to Mary Nell to walk through those guiding principles. Mary Nell, it's all yours.
Thank you, Anne. So our first principle is to build on the current public support to be bold around Medicaid. And as many folks on this call may have just participated in a campaign leading up to the election, it really won't come as a surprise to any of you that Medicaid has been a hot topic leading up to the midterm election, as well as just health care more broadly. That has been a hot topic issue. So we wanted to walk through a little bit of polling information about those two topics, health care more broadly and Medicaid more specifically. So as you can see from this polling data, which was conducted in June of this year, voters identified health care as the top issue factoring into how they were going to vote in our recent midterm election. And this was somewhat surprising because health care ranks above issues like the economy and jobs, guns, taxes, spending, and immigration, which are issues that often play a critical role in determining who someone is going to vote for. So healthcare in general was clearly top of mind for voters. But let's look now at what the data tells us about Medicaid more specifically. So this poll was conducted about a year earlier, in June of 2017, which was really in the throes of the ACA repeal attempt. And I think what you can see from this chart is plain and simple, Americans value Medicaid. This chart shows that 74%, nearly 3/4 of respondents, had a favorable view of Medicaid. And this support is not segmented to one particular party. It's found across all political parties, with 84% of Democrats, 76% of independents, and 61% of Republicans having a favorable view of Medicaid. They actually conducted a similar poll in early 2018, and this is when Medicaid wasn't quite as much in the news at the national level as the attempts to repeal the ACA and restructure Medicaid had kind of died down. But even this same poll in early of 2018, the support was sustained, and actually the percent of Republicans with a favorable view of Medicaid increased to 65%. I want to briefly highlight a group that you may be familiar with, the Little Lobbyists. So this was a group who emerged during the ACA repeal attempt, and they really helped educate policymakers and the public on the critical role that Medicaid plays for families of children who have complex medical needs and other disabilities. And really, evidence suggests that the damaging cuts to Medicaid that were included in the legislation to repeal the ACA ultimately led to that legislation's demise. And it was in part due to groups like Little Lobbyists who really helped demonstrate the value of Medicaid and how damaging those cuts to the program would be for families across the country. So really, their advocacy helps tell the story of how many different population groups, some of the ones Anne walked through earlier in the presentation, that Medicaid serves, and as a result, how many of us are directly impacted by Medicaid. So you'll see on this chart that 70%, 7 in 10 Americans have had a connection to Medicaid. So they were either covered by the program themselves, their child was covered, or maybe they had a friend or other family member covered by Medicaid. So Medicaid really isn't just an abstract policy for the majority of Americans. It's something that many of us have had direct experience with. So now that we have examined some national data, let's zero in on Iowa. Just about any time over the past couple years, you've opened up the newspaper, turned on the TV, or listened to the radio, there's been a story about Iowa's Medicaid program. As you all know, Medicaid emerged as a central issue in the governor's race, with each candidate holding differing opinions about how our state's Medicaid program should be administered. In a poll that was conducted right before the election, 64% of likely Iowa voters said that Medicaid privatization was a major consideration as they headed to polls. So in sum, reflecting over all of those national and state polls, I think you could say Medicaid's kind of having a moment. But as Anne said, now that the election is over and we have some clarity with the Reynolds administration's path forward to maintain the managed care model with some opportunity for reforms, our first guiding principle is really about building on that current public support and interest for Medicaid and be bold. And this is something, as you could see through Anne's history lesson, that Iowa really has a record of doing, because Iowans are innovators. We have a history of coming together to figure out innovative policies that meet the needs of Iowans, As Ann mentioned, Iowa was one of the earliest adopters of Medicaid expansion, and the bipartisan approach that we took as a state was a really unique premium assistance model that was in use by only one other state at that time. So bringing it back to this first principle, we propose to build on this opportunity and support what's working within our Medicaid program, fix what's not, and make sure that Medicaid is meeting the needs of Iowans. So that brings us to our second guiding principle, which is to take advantage of Medicaid's flexibility to meet the needs of Iowans. So federal regulations provide states with considerable flexibility to implement their Medicaid programs. As you all know, Medicaid is a joint federal-state partnership. So states can operate their Medicaid programs within federal standards and really a wide range of options in exchange for those federal matching funds. So each state's Medicaid program is very unique, and that's a reflection of the state's use of their existing flexibility within the Medicaid program, as well as waiver authority to design the program to meet their specific needs and priorities. So when we look at all of that flexibility, it's also important to balance the state flexibility with standards, accountability, and enrollee protections, because we want to have some level of consistency across the state Medicaid program, since they really are, as we've talked about, protecting some vulnerable Iowans. And that balancing act is really where the role of the federal government comes in. So you can see on this slide just kind of a high-level overview of the existing flexibility that states have to tailor their Medicaid programs to meet their own state's needs within the context of some broad federal guidelines and protections. So just as an example, states have some flexibility in the design of their benefit packages. Iowa has one of the more extensive dental benefit packages for their Medicaid program, and that package was designed under the flexibility granted to states. So that's just one example. So really, not only is there public will and support behind Medicaid, the state really has considerable flexibility to innovate. And as Administrator Verma says, to drive reforms that result in better health outcomes. So moving on to our third guiding principle, which is to be skeptical of promises of cost savings. So as you well know, Medicaid is a big budget item for states, but it also does bring in federal dollars. You often hear the figure $4 billion used as the Medicaid budget, and this figure does represent the total amount of Medicaid expenditures, which if we look at fiscal year 14 was about $4.2 billion. But as you remember, Medicaid is that state-federal partnership, and if you're looking at Medicaid strictly from the perspective of how much the state contributes, that figure is closer to $1.6 billion. Again, looking at fiscal year 2014, 63% of the total Medicaid expenditures were covered by the federal government. But nonetheless, Medicaid is the second largest budget item, behind only public education costs. And as such, it's often a target for cuts. And in fact, the potential for significant cost savings was presented as one of the rationales for transitioning to managed care back in 2015. But as we'll see over the next few slides, we should be cautious about promises of significant cost savings in the Medicaid program. An analysis of Medicaid managed care found little evidence that Medicaid managed care models were able to achieve cost savings while improving or at least maintaining access and quality standards. And this really isn't a knock at managed care. There's little evidence of cost savings because Medicaid is already a highly cost-effective program, which makes achieving any significant cost savings rather difficult. And that's because Medicaid's costs per beneficiary are substantially lower than for private insurance, and those increases have been growing more slowly than per beneficiary costs under private employer coverage. it costs Medicaid much less than private insurance to cover people of similar health status. For example, adults on Medicaid cost about 22% less than if they were covered by private insurance. So let's further unpack why cost savings in Medicaid are difficult to achieve. So Medicaid's reimbursement rates are already low. Medicaid provides more comprehensive benefits than private insurance at significantly lower out-of-pocket costs to beneficiaries, but its lower payment rates to healthcare providers and lower administrative costs make the program very efficient. And looking back, Iowa was already using cost containment measures like prior authorization and utilization review before moving towards managed care. And Iowa's per member expenditure rate was well below the national average. So we were already a very lean program, a very efficient program prior to our transition to managed care. And finally, an important thing to note is because, as we discussed earlier, Medicaid covers vulnerable populations. And as a result, there are certain federal protections in place that limit the extent to which states can charge premiums and cost sharing to its members. So there's also limitations on what the state could do in terms of bringing money in from the program in terms of cost sharing or premiums. There's also often somewhat of a disconnect between proposed cost containment strategies and the true drivers of Medicaid spending. Many of the politically possible strategies, both in Iowa and around the country, are focused on Medicaid populations that are already relatively low-cost users. The largest share of costs in Medicaid are for services for the elderly and the disabled, where there's rightly little appetite for benefit or enrollment cuts. So in Iowa, children and adults make up about 80% of Medicaid enrollees, but they only represent 35% of total Medicaid expenditures. Whereas on the other end of the spectrum, the elderly and disabled make up only 20% of the entire Medicaid population, but they constitute nearly 2/3, 65% of program cost. So there are some potential strategies that could achieve limited savings, but if we want to achieve realistic cost savings in Medicaid, we need to find the right solutions to the right problems. So I'm going to walk through a few different potential strategies, but before I do that, I want to reiterate this caveat. We again need to be realistic on cost savings. Some of these strategies that we'll walk through briefly have limited track record, or they're still in the early stages of application. And some of them require more spending up front for potential cost savings down the road. And finally, some require federal approval, which may or may not be possible. But again, ultimately, Medicaid is already an efficient program, so it's unlikely that we're going to really be able to wring out major cost savings from it without deeply harming consumers. I'm going to briefly walk through a few strategies that show some promise from other states or pockets of the state here in Iowa have already implemented. In the interest of time, I'm not going to go into a huge amount of detail on all of the strategies, but I did want to briefly provide you with a few examples. And none of these are really rocket science, but there is more that could be done in each of these areas in Iowa. So first of all, we could better leverage the healthcare workforce. And that would focus around expanding access to providers like nurse practitioners, community health workers, and doulas. There's also work that could be done to help high healthcare users manage their health more effectively, so focusing more on that small percentage of Medicaid enrollees who make up a majority of the cost. Other strategies include reduce unnecessarily costly services and reduce medical errors and preventable events. Address the root causes of poor health outcomes, which really relate back to social determinants of health. Just as an example, states can apply for Medicaid waivers to cover supportive housing services that can help individuals find and maintain stable and safe housing. And finally, tackle prescription drugs as one of the major drivers of high costs. There's potential for states to save money by passing laws or applying for waivers that allow them to negotiate additional supplemental rebates. And that's one area that I'm going to go into a slightly more detail to unpack for us today. So as you may know, state Medicaid programs participate in the Medicaid drug rebate program. And that really helps ensure that Medicaid gets among the lowest prices available to any payer. And I'm going to dip into the weeds here for a minute to help explain this, but bear with me. So drug manufacturers have to agree to participate in this Medicaid drug rebate program in order to have their prescription drugs covered under Medicaid. And so what this means is that for brand name drugs, the Medicaid programs are provided with a discount of either 23% off the average manufacturer price or the best price, which might be a large discount that a payer in the private sector, excluding Part D, might have negotiated. So the Medicaid program gets whichever is greater, either 23% off the average manufacturer price, or if someone in the private sector negotiated a discount larger than 23%, the state Medicaid program would get whichever was larger. But states can also negotiate additional or supplemental rebates tied to preferred drug lists. And this is where there are some opportunities to better leverage state negotiations with drug manufacturers. So making sure to extend the supplemental rebate to most or all drugs or drug classes, and ensure that rebates that MCOs might negotiate are passed back to the state Medicaid program. So there are some concrete steps that the state can take to potentially achieve cost savings that would not result in cuts to eligibility, benefits, or enrollment, and would actually target the real drivers of cost, high-cost complex patients, and high-cost medications. So that is guiding principle 3. We have a total of 7, so I'm going to move right along to guiding principle 4, which is to think long-term. So there's a growing body of evidence that shows that socioeconomic factors, physical environments, and health behaviors really drive health outcomes more than medical care. And Medicaid enrollees, who are low income in general by definition, are particularly at risk for struggling with basic needs such as food, clothing, and shelter. The National Association of Medicaid Directors actually submitted a letter to Administrator Verma last year recognizing social determinants of health and adverse childhood events as key cost drivers for children that impact their long-term health as adults. So Medicaid programs and managed care organizations can really drive the next generation of efforts to address social service needs within kind of an integrated care delivery platform in pursuit of that whole person care, which would include expanding access to high-performing medical homes and home visiting, as well as screening for family risk factors. However, in order to realize this potential, to be a driver of this change, we really have to make some deliberate choices within our Medicaid programs. And that's because MCOs have incentives, as we discussed, to better manage the chronic health conditions of adults. The payoff, which is reduced use of high-cost medical services, is immediate and within the contract period. But the incentives that work to maintain health in the adult population will not work for the child population, which again, as a reminder, is over half of all Medicaid members, because cost savings for the child population are realized well outside that typical three-year contract period. So even though MCOs may recognize the long-term benefits of providing high-quality preventive and developmental health services for children, the state must set expectations and establish explicit fiscal incentives and sanctions within the contract, the RFP procurement process, to really incent MCOs in the short term. Moving along to guiding principle 5, adopt evidence-based and informed strategies. So there is little evidence base for many of the Medicaid reforms that we have seen. We talked about the scant evidence of cost savings in relationship to managed care. And the evidence base for pediatric-specific interventions is even more limited because most practices are tested for the adult population. However, we do have some evidence-based strategies that we know work. For example, Iowa has tested evidence-based interventions in part of the state, including the pediatric integrated health homes for children covered by Medicaid, and we know these programs improve physical health and mental health outcomes for children. So there's a precedent and an evidence base for these programs and an opportunity for us to support these existing programs and expand them statewide. Guiding Principle 6 is to embrace engagement, accountability, and oversight. So we want to make certain that members' voices are heard in the design, implementation, and oversight of initiatives within the Medicaid program. Ensuring authentic member engagement allows members to help shape the decisions and practices related to the Medicaid program. And we have some great starting points with consumer representation on MAC, and each of the MCOs include members on some of their advisory boards, but more could be done in this area. For example, establishing a state-level stakeholder planning and oversight committee that was made up with at least 50% of Medicaid members, or requiring MCOs to have written plans on how they will ensure meaningful consumer engagement. And this is an ongoing role that could really help the MCOs get proactive suggestions from consumers instead of only hearing about grievances or problems. Continuing on with Guiding Principle 6, much of what the public knows, what legislators you might all hear from your constituents about Medicaid's performance is based on anecdotes. And stories matter, but we need to know more. And we must pair accountability with oversight. So IME, as you know, publishes extensive data in their quarterly reports, but we must ensure that this oversight actually translates into data-informed action and accountability. Iowa's Medicaid program must collect, analyze, and disseminate actual outcome data, not just process data, and we need that outcome data to include data by race and ethnicity. So as we know, Iowa is becoming more diverse, but it still remains predominantly white. So data in aggregate often looks pretty good, at least relative to other states, but when we break that data down, the picture is far less reassuring. Across indicators, children of color in Iowa fare worse than white peers, and the gaps are worse in Iowa than in many other states. The last time we did a data request from IME, which was a couple years ago, they only had enrollment data broken down by race and ethnicity for 40% of children in Medicaid and only about 30% of children in Hawkeye. And this is something that we need to work on because if you can't measure it, you can't manage it. And we want to make sure that Medicaid is working for all of our children and families in the state. Which brings us to our last guiding principle, to protect the coverage gains. And this is an area of vigilance for us this year. We need to make sure that reforms to Medicaid don't result in loss of coverage. We've seen from other states that barriers like work requirements, lockout periods, and time limits have been used to reduce enrollments and cut costs. For example, since August of this year, healthcare has been taken away from more than 12,000 Arkansans for not completing their complex reporting requirements around work. Similar requirements in Kentucky have tied the state up in very costly and ongoing litigation. And neither example is one that Iowa should follow. Medicaid exists to connect families to the care they need, not to add barriers to getting and staying healthy. So let's not backtrack on recent coverage gains. So we have seen a lot of success in Iowa, particularly relating to the number of uninsured Iowa children. So this reduction in the number of uninsured kids is really a reflection of the policy level and programmatic decisions our state leaders, such as yourselves, have made to expand coverage for Iowa's children and families. And Iowa has reached a historical level of health insurance coverage, with about 97% of kids covered and about 24,000 uninsured. Actually, just last week, new data came out, so you'll see 18,000 on the slide, but we actually, our rate of uninsured children increased slightly this year to 24,000. So that's a number that we want to track and monitor because it's a concerning direction that our coverage trend is turning. And while 24,000 is still a considerable number of uninsured kids, it's roughly equivalent to the population of Fort Dodge or Ottumwa. We really have to keep working to ensure that all kids have coverage and access to health care. And this is, has been historically a success story for Iowa, so we want to continue to ensure that our healthcare system is one that can expand and meet the needs of all Iowa's children. So on that note, I'm going to turn it back to Anne for a parting thought.
Well, yeah, a parting thought. And the great news is I'm going to let Al, a 13-year-old here in Iowa, actually deliver the parting thought. This is a video that we have produced to it's sort of a more public-facing piece. Obviously, we took you a little bit through the policy weeds. But we thought we would just end with this. It's sort of our ask of you as lawmakers. And there is some chance that if you are listening to this audio through your computer, you may have problems listening to this. I think as long as you're listening through the phone line, you should be good. It's just 2 minutes, so we won't keep you tied up with the video long, and then we'll get you back at the end, and if there's questions, we're happy to take them.
Dear Governor Reynolds and Iowa legislators, my name's Al. I want to talk to you about Medicaid. You know, the health insurance program that covers low-income children and adults, people with disabilities, and seniors. I know you've heard of it. I bet you know Medicaid makes it possible for thousands of low-income Iowans to get and stay healthy, to see a doctor when they're sick, get checkups, and go to the hospital without fear of choosing between their health and paying the rent. Iowans know this too, and that's why they care a lot about Medicaid. They also know our state's Medicaid program isn't working nearly as well as it should. Medicaid has become so politicized, it's been hard to have a productive conversation on how to fix things. But now the election's over. On behalf of more than 200,000 Iowa kids covered by Medicaid, I'm asking you to have that conversation. Please listen to Iowans. Build on the good things Medicaid does now. Fix the things that aren't working. I bet you know that more than half of the people enrolled in Medicaid are children. Services covered by Medicaid are recommended by the American Academy of Pediatrics as the services every kid needs to be healthy and thrive. That's really important because Medicaid covers Iowa's most vulnerable children, including 4 in 5 children in or near poverty, half of children with special health needs, and 100% of children in foster care. Right now, Iowa's Medicaid program isn't doing very well getting children important preventive services that lay the foundation for lifelong health. Here's one example. 69% of U.S. children on Medicaid are up to date on immunizations by their 2nd birthday. In Iowa, only 24% are. We can do better than that. We can find ways to modernize Medicaid without harming vulnerable Iowans who depend on it for their health care. It looks likely Iowa will continue to use managed care to deliver Medicaid services, like lots of states do. If that's our thing, let's do it really well. There are already lots of good ideas to make managed care work, and I bet we can come up with more. Iowans are good problem solvers. Let's solve Medicaid. It's just too important. Woo!
And Anne, you might be on mute if you're talking.
Thank you. Thank you for that heads up. I was on mute. Again, I think that's really our parting message. We'll be sharing it with our partners and sharing it on social media. And so I guess that's where we really will leave it today. We really look forward to working with all of you during session. We're accessible before session, we're accessible during session and after as well. I'm happy to, we'll hang here for just a minute in case anyone has any questions. You can just type them into the chat box in the lower left-hand corner of your screen. Looking pretty quiet. Well, I'll take that as we didn't leave anything too unclear. Again, we'll be following up with an email that'll have the slides, a link to the brief, a link to the video. Again, really appreciate your joining us today. And again, look forward to seeing you at the Capitol in January. Thanks so much.